Hi, I'm Emily.
And I'm Emily, and our project is the effect of combined transcranial direct current stimulation and bimanual intensive therapy on upper limb function in children with unilateral spastic cerebral palsy.
Unilateral spastic cerebral palsy, or USCP, is a pediatric physical disability caused by malformation in the brain within the first 2 years of life. This malformation can be caused by stroke or trauma in the part of the brain that controls function, movement, and sensation on one side of the body. CP is the most common motor disorder in early childhood, and although there are various types of therapeutic techniques to improve function in patients, these approaches fail to fully improve upper extremity function. There is an urgent need for therapies that can deliver strong improvements, but are more cost efficient and accessible to a majority of the families in the United States than what is currently available. So the prevalence of this disorder displays a high demand for new treatments. One of the most effective forms of therapy to improve upper extremity function in patients is bimanual intensive therapy, or BIT. Bimanual requires the use of 2 hands in order to complete an activity, and according to trials in 2011, BIT notably displays significant improvements in function in patients with CP. Another form of rehabilitation is TDCS, or Transcranial Direct Current Stimulation, which is a form of low-risk, non-invasive brain stimulation. TDCS creates a shift in the membrane potential of stimulated neurons, which aids muscle function. TDCS functions by sending a current from this box to these individual electrodes placed on the child's head. It was determined by Fusco in 2013 that 2 milliamps of anodal TDCS can boost the efficacy of this treatment.
Transcranial magnetic stimulation, or TMS, is another form of non-invasive brain stimulation. TMS is used to create a map of the motor cortex of the brain by generating responses that show a connection between a specific part of the brain and a muscle. These responses show hotspots, which will determine where the TDCS electrode should be placed for treatment. When using electrical brain stimulation, it is important to consider the corticospinal tract connectivity. Freeland 2007 found that 60% of children maintain contralateral control, so each hemisphere of the brain controls the opposite side of the body, and the more affected side results from the side of the brain with a lesion. The remaining 40% of children maintain ipsilateral control, where one hemisphere of the brain controls both sides of the body. Corticospinal tract connectivity greatly impacts the therapy received, yet past studies haven't taken the brain's laterality into consideration, which is something we will take into account in the present study because TDCS is significantly less effective if it is not targeted to the specific hemisphere of the brain. Previous studies have shown that both bimanual intensive therapy and TDCS are effective treatments for improving upper extremity function. For this study, we decided to combine these 2 treatments to create a conjoint therapy plan. We hypothesized that children who received the anodal TDCS targeted at the hemisphere controlling movement of the affected upper extremity will show greater improvements in hand function compared to those who received the sham TDCS. The null hypothesis is that the combined therapy does not show greater improvements.
Our study took 27 children aged 5 to 17 previously diagnosed with unilateral spastic cerebral palsy in a double-blinded randomized clinical trial. Out of these children, 11 of them were in our cohort that we worked with. These 11 children were divided into 2 groups. 6 of them were allocated to receive bimanual intensive therapy plus 2 milliamps of TDCS, and the remaining 5 received bimanual intensive therapy with a sham TDCS, which means that it was set at an intensity of 0 milliamps. In order to test the levels of hand function in these children, we performed these 2 hand assessments. The box and blocks test assesses manual dexterity and had children move these colored blocks over a barrier into the other side of the container, and it is measured in blocks moved per minute. The next test is the Jepson-Taylor test of hand function, which assesses the ability to perform activities of daily life, such as manipulating common objects. This is measured in time taken to complete the activity. 1 week prior to the start of therapy, children will complete these pre-testing assessments, which include these 2 hand function tests previously mentioned, as well as a TMS mapping session. Following the pre-testing, the therapy began, which takes place over the course of 5 days for 2 hours each day. The first 20 minutes consist of bimanual intensive therapy combined with TDCS, whether it be active or sham. The remaining hour and 40 minutes are only bimanual intensive therapy. Emily and I worked as interventionists, so we administered the bimanual intensive therapy to each of the children. Immediately following the training, the same tests of hand function and TMS are repeated, and they are once again repeated at a 6-month follow-up in order to see if these improvements are maintained over an extended period of time.
These 2 tables here show the results for the test of hand function for the 11 children we worked with, and the orange boxes indicate an improvement in levels of functionality. The Jepson-Taylor test of hand function showed improvements with a pre-average of 407.88 seconds and a post-average of 403.56 seconds. It is important to note that since this is a timed exam, a decrease in score is desirable. The box and blocks test also had a positive result with a pre-average of 16.09 blocks and a post-average of 18.36 blocks. The children who had improvements in both tests are denoted by an orange line connecting the boxes. Since this study is ongoing, the validity of our research cannot be compromised by releasing the group's data, and therefore unblinding the investigators. For this reason, it is unclear which of the 11 children received the active TDCS. However, we do have the averages for specific groups in regards to the entire study, which is 27 kids. In the Judson-Taylor test of hand function, it can be seen that the children who received the active TDCS had greater improvements. The kids who received ipsilateral TDCS, which is based on their corticospinal tract connectivity, had a difference of 45.09 seconds between the pre and post testing, which is a percent change of 29.83. The group who received the active contralateral TDCS also showed improvements with a difference of 26.27 seconds and a percent change of 6.71. The group who received the sham TDCS saw almost no improvements, so both groups receiving the active TDCS had improvements and the sham group did not. The box and block set showed similar improvements in hand function, with the active ipsilateral group having a difference of 3.33 blocks, which equates to a 11.24% change. The contralateral TDCS group had an improvement of 0.67 blocks between the two testings. This equals a percent change of 4. The sham group showed no improvements with a difference and percent change of 0.
The Judson-Taylor test of hand function, as can be shown in the first graph in the discussion section, had a p-value of 0.43 that was found with the student's t-test, which is not statistically significant. However, there are many notable improvements in individual groups. Since the value for the 11 children we do not have the ungrouped data, the p-value is higher than it would be if the children who received active TDCS were separated from that group. The Boston blocks test, as can be shown here in the second graph in the discussion section, did have a significant p-value of 0.0099. And once again, it would be even lower if the different treatment groups were separated. The box and blocks test, as shown by Hare in 2014, is one of the most widely used and valid forms of assessing hand function.
The results of our test show that after 10 hours of intervention, overall levels of upper extremity function improved. This supports our hypothesis that the children who received the active TDCS will have greater improvements than the children who received the sham. Additionally, in the future, we would like to conduct a 6-month follow-up and analyze that data. Our research is significant and novel because it is the first study that shows the effect of these combined treatments, and it is the first study that takes corticospinal tract connectivity into account. The combined therapy can be applied to children with USCP, and that is notable because previous therapy options were intensive and costly, requiring about 90 hours of therapy to achieve improvements.
Thank you. Any questions?